Hello everyone. Today we will discuss about antimalarial drug therapy. So, malaria is a vector-borne parasitic infectious disease. It's a vector-borne parasitic infectious disease. It is mainly caused by the 4 species. These are Plasmodium vivax, Plasmodium ovale, Plasmodium falciparum and Plasmodium malariae. The 5th species known as Plasmodium knowlesi, which is primarily a animal pathogen. But it is known to cause human malaria in humans also. Has been reported to cause malaria in humans. I am not going into the detail of life cycle of malaria. Here we will see some common anti-malarial drugs and the treatment regimen. So, common anti-malarial drugs. The first one here is chloroquine. We will discuss about chloroquine here. The mechanism of action. So, chloroquine is mainly the erythrocytic schizontocyte of all the species of Plasmodium. So, it is an erythrocytic schizontocyte of all the species of Plasmodium. So basically the Plasmodium, that is the malarial parasite, it will digest our hemoglobin to heme and globin. So Plasmodia will digest the hemoglobin to heme and globin. This globin is used by the parasite for its nutrition. This heme is toxic to the malarial parasite. So, it is converted into its non-toxic form called as hemazoin by the polymerase enzyme that is secreted by the parasite. So, this heme, it is toxic to the malarial parasite. So, this is being converted to hemazoin. It is a non-toxic form. This is a non-toxic form to the malarial parasite. This is converted with the help of the enzyme called as polymerase that is being secreted by the malarial parasite. Our chloroquine, it acts here. It inhibits the conversion of the heme to hemazoin and it forms, this chloroquine forms chloroquine and heme complex. This is being formed. So the chloroquine and this heme complex, this damages the plasmodial membrane, thereby destroying the malarial parasite. So this is the mechanism of action of chloroquine. So its antimalarial activities, it acts against the erythrocytic chitones of Plasmodium malariae, oval, vivax and chloroquine sensitive Plasmodium falciparum, but it does not have any action against the hypnozoites of Plasmodium vivax. So it do not have action against the hypnozoites. Of Plasmodium vivax. Okay. Next we will see about the pharmacokinetics of chloroquine. Pharmacokinetics is this chloroquine is available in 250 mg tablet, in which it contains 150 mg as base. Contains so the dose is calculated based upon the base. Okay. It has a good oral bioavailability. So it reaches the plasma therapeutic concentration within 30 minutes. So it reaches therapeutic concentration within 30 minutes of administration. It has a long half-life. So its T-half is around 10 days. Okay, this is the pharmacokinetics of chloroquine. Next we will see its adverse effects. There are no serious adverse effect with the usual dosage. Okay, it mainly has nausea, vomiting with transient headache. So this mainly have high affinity towards the melanin containing parts such as the skin and the eyes. So increased affinity towards melanin containing parts. Thus it causes pruritus and irreversible visual impairment with a prolonged prophylaxis. When taken in a prolonged duration as a prophylaxis, it can also cause irreversible visual impairment. Okay. The contraindications are, the absolute contraindication is known hypersensitivity, the relative contraindications are patients with epilepsy and psoriasis. Because the patient having a psoriasis, a genetic component, when you given a chloroquine, it can exaggerate the current situation. Okay, this is about the chloroquine. So we have seen the mechanism of action, pharmacokinetics, adverse effect and its contraindication. Next we will talk about the second drug, that is quinine. So the mechanism of action of quinine here is, it is same as chloroquine. So it is similar to chloroquine. We will see its antimalarial activity. It acts against erythrocytic chrysalis of all the plasmodial species and also against the gametocytes. This doesn't have any action against the hypnozoites. So it do not have action against hypnozoites. Okay. Next it's pharmacokinetic action. These two also have a good oral bioavailability. Next, it reaches its peak plasma concentration within 1 to 3 hours. Its T half is 10 hours. While for chloroquine it is 10 days. For quinine it is 10 hours, 10 to 12 hours. Okay. Next we will see its adverse effect. It has a symptom complex that is known as synchronism. It is a symptom complex containing hearing difficulties, visual impairment, tinnitus, sorry, it's not visual impairment, it is hearing difficulties, tinnitus, vertigo and dizziness. Hearing difficulties, tinnitus, vertigo or dizziness. These are completely reversible. So it can also cause hypotension when you give it in a fast IV administration. So it can cause hypotension following a fast IV administration. It can cause hypoglycemia in children. So the blood glucose levels are checked when the child is on treatment with quinine. In G6PD patients, deficient patient, it can lead to hemolysis, mainly intravascular hemolysis. So what are its contraindications? So contraindications are G6PD deficient patient when they have a known hypersensitivity, and cardiac disease. So this is about the quinine. Next we will see the third common drug, that is primaquine. Its mechanism of action. So primaquine is mainly converted into electrophiles, so that destroys the parasite's mitochondria by generating a reactive oxygen species. Okay. So primaquine is being converted into electrophiles. This destroys the parasite's mitochondria. by generating reactive oxygen species. Okay, it's antimalarial action. So it acts against all the hypnozoites of Plasmodium vivax and oval, and also against the gametocytes of all the malarial species. So it mainly acts against the hypnozoites of Plasmodium vivax and Plasmodium oval, and it also acts against the all the gametocytes. Okay, this is its antimalarial action. Next we will see its pharmacokinetics. This also have a good oral bioavailability. It is mainly metabolized by the hepatic pathway and small amount is excreted through urine. So it is mainly metabolized by hepatic pathway and small amount is excreted through urine. Okay, its adverse effects are mainly it has GI side effects. Like nausea, vomiting, and hematopoietic side effects. Hemopoietic side effects are methemoglobinemia, leukopenia, suppression of myeloid series, and it can also cause hemolysis in G6PD patients. So it is mainly avoided in patients with G6P deficiency. Okay, so this is about the primaquine and its mechanism of action. Next we will talk about sulfadoxine and pyrimethamine. So sulfadoxine pyrimethamine's mechanism of action is it acts synergistically against the dihydrofolate reductase and dihydrooptrate synthase enzymes, thereby inhibiting its actions and destroying the parasite. So it acts synergistically against dihydrofolate reductase and dihydrooptrate synthase enzymes, thereby inhibiting the nucleic acid synthesis. In the parasite. Okay, so this is the mechanism of action of sulfadoxine and pyrimethamine. So it is antimalarial action is it acts against the schizoins of Plasmodium falciparum and it has a weak activity against the vivax. So antimalarial action So it acts against the schizoins of Plasmodium falciparum, and it doesn't act against the hypnozoites and gametocytes, and it has a weak action against the Plasmodium vivax malariae. It do not have action against hypnozoites and gametocytes, and it have a weak action against Plasmodium vivax. Okay, these are its antimalarial action. And pharmacokinetics is it is a highly protein bound, so its elimination half-life is long. So this is about sulfadoxine and pyrimethamine. Next we will see about the artemisinin. Artemisinin mechanism of action. So artemisinin compound contains a peroxide bridge. So it contains peroxide bridge. Okay, the heme ion cleaves this peroxide bridge and forms a reactive free radicals which damages the parasite membrane by covalently binding to the membrane proteins. So I'll tell it through a flow chart. So the heme ion that is present in which the parasite is being present, the erythrocyte that contains the parasite, in that the heme ion cleaves the peroxide bridge. Okay, so this forms the reactive free radicals. This reactive free radicals then damages the parasite's membrane. How? By binding to the membrane proteins. So this is the mechanism of action of artemisinin. So it is a rapidly acting schizontocidal drug on all the stages of parasites of all the species. So it is a schizontocidal drug on all the stages of parasites of all the species. It doesn't act against the hypnozoites. So artemisinin derivatives. So artemisinin derivatives are, first is artesunate, artemether, arteether, and arterolane. So artesunate, it is a water soluble. Can be given in oral, IM and IV. Next artemether, it is a lipid soluble. It is given in oral and through IM. And arteether is an ether derivative and it can be used only as IM. So these are the derivatives: artesunate, artemether, arteether and arteriolane. So next we will see the artemisinin combination therapy. So why and what is a combination therapy? It is a simultaneous use of two or more individually effective schizointerstitial drug with a separate mode of action and separate targeting of the biochemical stages of parasites. Okay, so it is a simultaneous use of two or more schizointerstitial drugs with separate mode of action and separate targeting of biochemical stages of parasite. Okay, in this artemisinin components are short acting drugs. So monotherapy can needs to be extended beyond the disappearance of parasite to prevent the recrudescence. So you are combining it with the long acting drugs. Okay, so WHO recommendations are artemisinin and its derivative as a cornerstone of antimalarial therapy in view of they have a high parasiticidal action. So WHO recommendation is to use artemisinin and its derivative. So since they have high parasiticidal action. High parasiticidal action is they can decrease the parasite load by approximately of 10 to the power of 8. So they can decrease the parasite load like by 10,000 fold in every asexual cycle. So they can decrease the parasite load by 10,000 fold in every asexual cycle. So this is why artemisinin is used in the combination therapy. So we will see the regimens for each of the complicated and uncomplicated malarial infections. In the we'll